At the last topic of fragment of the day, and first of all, I would like to disclose that the duty to do the moderation of the topic has been assigned to me just a few hours earlier, when I came to know that the original moderator has some medical emergencies. So pardon me, I have tried my best to manage the things. And just to begin, let me introduce my panelists. So first of all, Dr. Ajinkya Raje Nimbalkar. He is practicing at Baramati, district Pune, and practicing at Chintamani Hospital and ISU Baramati, and interventional bronchoscopy and thoracoscopy. So welcome, sir. Next, Dr. Rohit Vingadeve. He is MD Chest, former consultant Sevari TB Hospital, Mumbai, and now consultant pulmonologist at Pushkal Avinav Multi-Speciality Hospital, Sangli, Maharashtra, with special interest in bronchoscopy, thoracoscopy, and sleep apnea. And our third panelist, Dr. Devendra Yadav, is MD Respiratory Medicine, current affiliation, consultant pulmonologist, Homi Bhabha Cancer Hospital, Varanasi. So, today, our topic is the one that it is no less than 60% of our pulmonology practice, the asthma, and often we overdiagnose it. So it is worth discussing with asthma mimics when wheeze is not what it seems. So just I am taking you through very common case scenario. 45-year-old sedentary women presenting with a 6-month history of intermittent wheezing, shortness of breath, persistent dry cough, reports that her symptoms are worse at night and after meals often, occasionally after climbing stairs or during episodes of stress. Based on her presentation, she was initially diagnosed, as most of us will do, with asthma and prescribed inhaled corticosteroid and bronchodilators, which provided partial relief. However, she returns to the clinic with worsening symptoms. So the introduction to asthma mimics, these are the conditions presenting with symptoms similar to asthma: wheezing, cough, dyspnea. So these are one of the cardinal symptoms that we face day in, day out in our pulmonology practice. Common mimics include vocal cord dysfunction, or in umbrella term which we call inducible laryngeal obstruction. The lower airway causes COPD, bronchiectasis is very common. Then the gastrointestinal causes like GERD or laryngopharyngeal reflux disease. The age-old term cardiac asthma or the congestive heart failure issues. Some interstitial lung disease can also masquerade like asthma, and most importantly hypersensitivity pneumonitis. Some pediatric causes, like just my previous speaker dealt with the adult case of acquired tracheobronchomalacia, but it may be congenital, foreign body aspiration, and bronchiolitis, which are common causes in pediatric groups. Some neuromuscular causes like GB syndrome or myasthenia gravis, though uncommon, it is worth mentioning. And definitely the psychological causes like panic attacks and hyperventilation. And accurate diagnosis is crucial for effective management. So what are the importance of differentiation? Misdiagnosis often leads to inappropriate treatment, increase in morbidity. Mimics may have distinct underlying pathophysiology, so we need to address those for proper management. Some may have structural abnormalities, cardiac, gastrointestinal causes, neuromuscular as well. And most importantly, they may coexist with asthma often. They are not actually watertight. So what are the diagnostic challenges? Overlap of symptoms with true asthma, variable response to standard asthma therapies, limitations of routine diagnostic tools like spirometry, and need for targeted investigations like imaging, the advanced PFTs or laryngoscopy. So the objectives of panel discussion today is to explore the approaches to differentiate asthma mimics, to discuss the role of advanced diagnostics and multidisciplinary care, and to share some clinical practical insights for improving patient outcomes. So to start with, my first question to Dr. Rohit: what are the key clinical and historical features? Because we all know, to begin with, asthma is basically a clinical diagnosis which has to be supported with spirometric evidences or establishing variable airflow obstruction. But what are the key clinical and historical features that help distinguish asthma from its common mimics?
As we know, bronchial asthma is a heterogeneous disease with airway hyperactivity, which is and it presents with cough, breathlessness, paroxysmal breathlessness, and with variable reversibility. There are several set guidelines by GINA for diagnosis of bronchial asthma, as the FEV1 by FVC ratio should be less than 70%. The FEV1 post bronchodilator should at least have 12% or more than 200 ml of increase in the FEV1. Then there should be at least 20% reduction in FEV1 post methacholine challenge test, and there is variability increase, at least 12% increase in the PFR over a period of time. So if patient is not fitting in these criteria, we should at least think on some common asthma mimics. Like if the patient is more than 40 years of age, having recurrent chest infections, he is chronic smoker, we can consider bronchiectasis in these such patients. If patient is having recurrent allergic rhinitis, then watering from the nose, watering from the eyes, then we can consider allergic rhinitis or allergic conditions in such patients. If patient is the symptoms is increases on exposure to the irritants or some perfumes, patients the symptoms is increase on keep on increasing on top, then we can consider in such patients like tracheal hypersensitivity or vocal cord hypersensitivity in such patients.
Okay, so starting right from the upper airways, there could be many points which can lead us to think beyond asthma actually. Just as I've been pointed out, that if the patient is having more of this cough and shortness of breath while speaking, or at the peak of the exercise, or while on stress, and with some vocal cord issues or voice issues, definitely we should think about the vocal cord dysfunction. And these features may coexist with asthma. So even though we are dealing with some asthma mimics, the asthma diagnosis should not be excluded actually, because they may coexist. So my second question to Dr. Devendra: how should we diagnose and manage vocal cord dysfunction, as this is one of the most common associated or mimic of asthma in patients presenting with asthma-like symptoms?
Sir, vocal cord dysfunction generally presents with the symptoms like symptoms of the asthma, just like shortness of breath, that is acute, intermittent. There is a chest tightness along with throat tightness, and more difficulty in breathing while inspiration process. So mostly these symptoms are triggered by like some stress, some anxiety situation, some laryngopharyngeal reflexes, GRD, or even exercise also. On basis of this clinical history and science, we will proceed for the further investigations. As in the cases of asthma, we also do spirometry in this case, and in cases of vocal cord dysfunction, there is a flattening of the inspiratory loop of the in the spirometry. And sir, laryngoscopy is diagnostic for these patients. While in laryngoscopy, mainly it's better to perform during the phases of the symptoms or during the exercise phase. So it will be more diagnostic. And laryngoscopy findings include a position of the vocal cords, while in the posterior part there is a small narrow opening, diameter opening. And for the management, sir, management includes the to remove the stress factors, psychosocial counseling, speech therapy, and treat the GRD and other aggravating factors.
Yes, very nicely done. Actually, the suspicion should come from our end. Then the spirometry is our domain. So once we have this inspiratory lymph flattening along with the typical symptoms of throat tightness, having predominant cough on when the patient is speaking in phone or having stress. So once we find these features, then we have to involve our ENT colleagues to do a good laryngoscopy, and the diagnosis is made, and then the treatment mainly is the voice therapy. Now the third question to Dr. Ajinkya: what is the role of GERD or another mimic, that is laryngopharyngeal reflux disease, LPRD, in asthma mimics? The clinical markers, and when should esophageal studies be considered?
Actually, one of the mimics of asthma is the GERD, gastroesophageal reflux, where 20 to 30% there is a combination between the asthma and GERD. So basically, GERD patients complaints cough that increases at the night, cough increases after the meal, cough mostly increases during the meal, cough that increases when he is sleeping. So these are the key points that we, and some patient also complains about the heartburn and regurgitations. And some variant is that silent reflux, where there is a cough is there, but the reflux is very low, so patient cannot identify that it is a complaint of GERD. So GERD can be diagnosed with the esophagoscopy. First is the history of heartburn. Second is the imaging test like esophageal gastroscopy, where gastroscopy is we can rule out the gastritis, whereas esophagitis or peptic ulcer that we can rule out with the esophagoscopy. Second is the pH monitoring of the stomach for 24-hour pH monitoring. So that can also monitor the pH of the stomach and the reflux over the esophagus and reflux tract of the pharynx and the larynx. So laryngoscopy also can diagnose the inflammation of the larynx and posterior pharyngeal wall inflammation. So lastly is the manometry of the stomach is also diagnostic of if there is a problem with the lower esophageal sphincter. So these are the studies we can be taken care are diagnosed with the related to the asthma, GERD related asthma.
Yes, quite true. And the point to make here is the GERD may present only with respiratory symptoms like cough, chest tightness and wheezing, without the typical symptoms of heartburn or dyspepsia. That has to be kept in your mind. So the next question to Dr. Rohit: spirometry may not be diagnostic in asthma mimics. How do advanced tests like methacalling challenge or imaging contribute? At this question, I would like you to mention or stress upon the other lung function test along with this BPT, and because I have a separate question on imaging, please.
When we say spirometry might not be diagnostic in asthma mimics, there is a catch. On PFT report, there is a special diagram is there. It's called as flow volume loop. And with the help of that flow volume loop, when the conditions are there, like gastroesophageal reflux disease is there, then rhinosinusitis is there, obesity is there, obesity hyperventilation syndrome is there. In such cases, the inspiratory flow loop, we can see the poor inspiratory effort and incomplete inspiratory flow loop in the FV loop on the spirometry. And in case of vocal cord dysfunction, there is complete flattening of the inspiratory loop on FV loop diagram. So in case of intrathoracic obstruction or any tracheal endotracheal papilloma or central airway obstruction, there is flattening of the expiratory loop on FV loop diagram. So spirometry is not like it is not diagnostic in asthma mimics, but when we see the flow volume loop, we quite diagnose quite a few things on related to asthma mimics on spirometry also. In imaging modalities, we can do HRCT chest in case of tracheomalacia, in case of central airway obstruction, or in case of dynamic airway collapse due to lymphadenopathy that might be due to tuberculosis or malignancy in such cases.
Yes, so apart from spirometry, do you actually suggest that the other advanced tests like phreno impulse oscillometry or this bronchial challenge test can confirm the diagnosis of asthma when we are in a little bit of doubt, or where the coexistent asthma may be there along with the mimicking aspects.
In case of Pythagorean challenge test, we generally do not perform in asthma mix in our hospital. But other imaging modalities we can surely do to differentiate from asthma and asthma mix.
Okay. So, going to the next question to Dr. Devendra. How can we differentiate between cardiac asthma and true asthma, and what investigations are most useful?
Again, sir, it's a cardiac asthma symptoms, like it is mimicking asthma, but mostly due to cardiac causes. So we proceed with the history wise. There may be history of the angina, ischemic heart diseases, hypertension. Each profile will be slightly different, mostly in 40s and 50s. And sir, symptoms mainly dyspnea, which will be aggravated on supine position, and there are presence of wheezes, presence of pedal edema or facial edema. These features are mostly because it is due to congestive failure or congestive heart failure. So these symptoms will be prominent. Investigation wise, sir, we will proceed with the ECG, chest X-ray. In ECG, there may be changes suggestive of the myocardial infarction, and changes may be related to the hypertension, like left ventricular hypertrophy. In X-ray, sir, there may be presence of the bilateral effusion or features of the pulmonary edema, and we also go for the lung ultrasound if it is cardiogenic pulmonary edema causing the cardiac asthma, and also one serum marker NT-proBNP, which is mostly high in the cases of the congestive heart failures.
Yes. So NT-proBNP
And 2D echo.
2D echo, and if there we have some suspicion of any valvular issues, then we can order for echo Doppler also.
Hello. Can I just, excuse me? Can I just ask one question?
Yes.
Yeah. I remember this cardiac asthma word was a very old word.
Yeah.
And-
because
and-
we are dealing with asthma mimic, so
Yeah.
purposefully I have kept this word.
Okay.
So purposefully,
Because we try to tell our students in college that there was a time when 2D echo was not rampantly available, and now it's very easy to differentiate between left ventricle failure and pulmonary asthma. So we should not be using this cardiac asthma
Sure,
because it can
you're right.
create into, just like our undergraduate students and postgraduate student doesn't come out with a 60-year-old man with a history of 5-year history of breathlessness, it's asthma only. So for them everything is asthma until proved otherwise. And we have to really tell them that you have to have from clinical history that asthma has presented in the childhood and this is COPD. So right from the beginning, because further treatment and investigation all go in that direction. So whether we should use this word even today, or should we always tell that now in an era where even every small places like Taluka is having one or more 2D echo machine and cardiologist, it's very easy to differentiate.
Please read it as congestive heart failure mimicking asthma. So the next question to Dr. Ajinka, what is the approach to evaluating asthma mimics in pediatric patients? What are the entities that we should consider, and especially congenital airway anomalies or foreign body aspiration?
So there are two ways. The first is the congenital anomalies. There could be tracheomalacia, laryngomalacia, tracheolaryngomalacia, tracheoesophageal fistula. So these are the modalities mostly gives proper history. Second thing is the investigation with the help of pediatric surgeon or pediatrician. So they can diagnose the congenital airways with the help of radiologist. We can get the any abnormality in the lungs or like bronchiectasis or cystic fibrosis. We can rule out with the congenital airways anomalies. Some genetic problems that can be ruled out with the blood test. And in case of foreign bodies, the foreign bodies are the two types of foreign bodies. First is the radio-opaque foreign bodies that can be easily diagnosed with the X-ray test. But the real tricky one is the radiolucent food particle type of foreign bodies. So these can be diagnosed with the history of sudden onset cough, sudden onset choking. There is history of foreign body aspiration and indirect signs on the X-ray, that is hyperinflation on the one side of the chest. There may be some, if there is a complete blockage, that can cause the collapse of the lungs, and if there is some inflammation or infection, that may cause the recurrent pneumonitis. So the X-ray, proper history, and with the help of radiologist and pediatric surgeons, we can diagnose congenital anomalies and the foreign bodies in the pediatric age population.
Yes. So history of sudden onset respiratory distress followed by recurrent chest infection, and in radiology unilateral or localized hyperinflation or atelectasis. So these are the clues. Now the next one to Dr. Rohit. How should clinicians address drug-induced asthma-like symptoms from medications like beta blockers or ACE inhibitors?
In case of drug-induced asthma-like symptoms, as like drug-induced cough or bronchospasm, that depends on which drug is causing that. In case of cardiac patients who are on ACE inhibitors, we can tell them to shift to angiotensin receptor blockers. And if some patients are on beta blockers, we can go on cardioselective beta blockers like atenolol, metoprolol. And in case of other conditions like NSAIDs or patients who are taking painkillers, we should tell strictly in asthmatic patients that not to take aspirin, because it can cause severe bronchospasm, hypersensitivity reaction. In spite of that, simple paracetamol in asthmatic patients is more useful than other NSAIDs.
Yes, so the historical association is very important, because often asthma will coexist with these drug-induced aggravations. So when the symptoms have developed after starting these medications or not, those things are very important. So the next question to Dr. Devendra. What strategy should be adopted for occupational asthma mimics, and how can hypersensitivity pneumonitis be diagnosed? So talking about occupational asthma mimics, I am mainly pointing at this hypersensitivity pneumonitis.
Sir, as occupational asthma mimics, so asthma-like symptoms while workplace exposure, but we are discussing the mimics. So hypersensitivity pneumonitis is basically it is a presence of the symptoms of dyspnea, cough, fever with chills, and with the exposure to the allergens, which may be either at the workplace, it may be due to exposure to other environmental antigens, it may be due to farming or some other places. So basically it's a clinical diagnosis, and on basis of clinical diagnosis we further proceed for the blood investigations. We will go for the when we are suspecting a particular exposure to the antigen, so we are going for the IgG antibodies, eosinophil counts, and X-ray and HRCT, sir. HRCT thorax will be diagnostic in acute and chronic cases. Sir, in the acute cases, basically upper and middle lobe predominance of the GGOs with centilobular nodules, and in the chronic cases or fibrotic cases, more prominence of the interceptal and interlobular thickening suggesting the fibrosis. Also, sir, we go for the bronchoscopy and Havas. In BAL, there may be presence of the lymphocytosis, mostly more than 20% lymphocytes counts in these cases. And additionally, sir, we will go for the spirometry also.
Yes. So the suspicion should come from the history itself. So the serology, as you have mentioned, is not that much contributory, but they can be of supportive evidence. But
yes,
the
sir.
history of association of some suspected antigens, the occupation like farming or the people who are associated with birds or carpenters, these things are very important. And after that, we should rely on the radiological evidences, the CT scan, and bowel fluid also can help us in making diagnosis. So the next one to Dr. Ajinka. Can you throw some light on clinical features and management of psychological asthma mimics? Do they coexist with asthma itself? This is a very common finding in our day-to-day practice.
mostly anxiety and the depression is increasing day by day. So mostly it is seen with the peer group of patients between 15 to 20 years when there is a college going exams. But the psychologically mostly the anxiety or depression. So that may causes the hyperventilation syndrome that can also triggers the asthma. Secondly is the anxiety causes some types of bronchoconstriction that can also mimics the asthma. And third is the long-term depression that causes the social withdrawal and reduced intake of food. So decreased appetite that causes the reduced immunological response, and that patients are vulnerable for viral and bacteriological infection. So that can cause the asthma mimic or chronic bronchitis type of features in psychologically associated with asthma.
Yes, very true. But again, the thing that it may coexist with asthma. So once we are dealing with a typical panic attack with tingling, numbness, hyperventilation. But if there are, we should not stand only on a psychological basis. We should ask the patient about the relevant histories like childhood asthma type symptoms, any family history, any other atopic histories, and then we should do the spirometry and try to establish the variable airway obstruction as much as we can. So the next one, Dr. Rohit, what role does imaging such as chest X-ray or CT scan play in differentiating asthma from its mimics, and when should these modalities be prioritized in clinical evaluation?
Sure. Radiological modalities like CT scan and chest X-ray help to diagnose asthma mimics and differentiate it from asthma. But that should be advised only after performing a clear and spirometry. After the spirometry, if and after giving a trial of bronchodilators, the patient is not improving, we can do the HRCT chest, and in case of tracheal malacia or any intrathoracic obstruction or any dynamic airway collapse due to mediastinal lymphadenopathy, that is due to tuberculosis, which is more common in our subcontinent, or due to any malignancy, we can diagnose it on the HRCT.
Yes, definitely. So those two important points, tuberculosis and malignancy. So those things should also be always be kept in our mind while, especially we are dealing with any chronic cough patients, whatever the nature may be. So there comes the role of this chest radiology. Now to Dr. Devendra, just taking cues from the last question, what are the key clinical red flags that should prompt a clinician to suspect a diagnosis other than asthma, particularly in cases of persistent or atypical symptoms?
Sir, our red flags will include the first will include the symptoms disproportionate to the our clinical or working diagnosis. If we are suspecting, we are treating on the basis of asthma, and there are patient desaturating, there are signs of the tachypnea, tachycardia, there are facial edema, facial puffiness. So, and also other symptom of asthma mimics. In this case, sir, we should suspect for the somewhere central airway obstruction, and it is, since it is quite fatal, so central airway obstruction should be evaluated. And the features include the facial puffiness, prominence of the neck veins, neck swellings, and for evaluation, sir, examination and the of the neck nodes, and investigations. We may proceed for the CT neck and or ultrasound neck with CT thorax to rule out the some benign or malignant tumor. Also, we will go for bronchoscopy to rule out the endobronchial obstruction, which is causing the red flag signs.
Some more basic clinical signs like significant weight loss, any history of hemoptysis or recurrent expectorations, so signs of any signs of infection. So those things also to be kept in our mind when we are dealing with chronic cough specifically. So the last question to Dr. Ajinka, how can a multidisciplinary approach improve diagnosis and management of asthma mimics? Because we have been talking about various causes, right from the upper airway to the lower airway to cardiac causes and then systemic causes, psychological, gastrointestinal. So how does a multi-speciality approach may improve the diagnosis?
So basically, asthma mimics where you have to basically diagnose the cause of asthma-like symptoms. Firstly, we need the cardiologist to rule out the cardiac disease. Secondly, is in the pediatric cases, we need the pediatrician and pediatric surgeon so that can diagnose the tracheoesophageal fissure, foreign bodies, these type of cases that can be diagnosed. Thirdly, is radiologist is also important because he can also give the CT diagnosis or X-ray diagnosis that can if there is any problem of ILD, foreign bodies or any space occupying type of lesions are there. Third is the pathologist, proper pathologist is also important so that in the cases of bowel eosinophilia, blood eosinophilia, in case of cardiac cases, the BNP, pro-BNP, anti-pro-BNP, these type of markers can also help to diagnose the asthma mimics like symptoms. Fourth is the gastroenterologist that can also help to diagnose whether there is a GI reflux is there or gastric ulcer is there, so that can cause the asthma-like symptoms. And lastly is the proper dietitian is also important because dietitian also can reduce the GIRD symptoms and if there is a symptoms associated with the obesity. And lastly, the proper pulmonologist who can diagnose the patient with the proper history, proper diagnostic tools like spirometry, IOS, CT scan, X-ray chest, flexible bronchoscopy. So that is also helps to rule out the other causes of asthma mimics like symptoms or causes.
Yes, certainly. So we being a pulmonologist would play the central part, but we should keep ourselves open to involve other disciplines as well as and when needed. So here we come to the end of the questions, and so I would like to request any of the subject experts to draw a conclusion. Any remarks?
Very well conducted panel discussion. What happens is we tend to think that all these mimics also mutually exclusive from asthma. They can coexist with asthma is what we should remember. An asthmatic may have GERD, so treating GERD and asthma simultaneously is equally important. So just a message that it is not necessary that these mimics may not coexist with asthma. You may have an asthmatic landing with cardiac failure as well in advanced stage. So keep your mind open. Don't shut your mind just because you have cardiac failure. That doesn't mean that the patient cannot be an asthmatic. So that's one thing that we should always keep in mind.
Yes. So thank you. Any more comment?
Actually, both of us are seeing urban population of East India. So in our clinical practice, whether hypersensitivity pneumonitis and ABPA is most common coexisting conditions with asthma, or those are the most common asthma mimics. Your comment?
No, I should not say that hypersensitivity pneumonitis is the most common, but definitely it is not that much uncommon. That I must agree with you. But commoner are the GRD, those psychological issues, panic attacks in young females, and the COPD also. Those are the commoner. But definitely we should keep a proper history just to exclude whether we are dealing with any hypersensitivity pneumonitis or not. To begin with the evaluation.
Thank you, Dr. Datta, for your wonderful discussion. If you have any questions, we can entertain them.
I was just waiting for. So, but we are already running very late. But just two things I wanted to know. The differentiating from like that, as you said, combination of suppose somebody is suffering from HP, and how will you differentiate from asthma? So now we know that if asthmatic have a very classical history, right? We know in most of the patient may not have their PFT done, but PFT will show in the earlier phase of life reversibility. HP will not show. So if we have HP, whether it is acute or whether it is subacute or chronic, we'll have some radiological finding. And with the availability and what COVID has done, that even people are very forthcoming for HRCT chest, which earlier was not the, they used to ask question whether it is really required. Now most of the time I feel that not only urban area, but even in rural area, you advise them and they are not very reluctant. Most of the 9 out of 10 times they will say they'll go ahead if the diagnosis is at fault. I wanted to make a point that AC inhibitor. So this is my experience that AC inhibitor, even if the patient has been taking for years, then he will not develop asthma. He may develop asthma anytime. And what is the comment of panelists? And even if you stop, it is not common to see that the cough or the cough, particularly I'm not talking about asthma, I'm talking about AC induced cough. They will not disappear, it will not disappear. Only thing is that we have to see the list of drugs that somebody is taking, and if you have ruled out other thing, then that comes a possibility that we have done everything now. This also remains one of the cause and stop it. So what are your take on these 2 points? That it is not like many other drugs where drug is started and now you see this as an adverse event. This drug has been going on for many months, and at some time the cough, patient may complain of cough. And when suppose somebody is getting investigated as a cause of cough, where a lot of pharmacological, a lot of consultation, ENT consultation, somebody consultation has been done, and there is no response. And usually at that time they come to us that is it, can you find out is it the cause? So it's just by rule of thumb that stop that and see what happens. So do the cough disappear immediately? In my experience, I have seen that it doesn't disappear completely immediately. It may disappear completely, but it takes few weeks.
Yes, certainly. If there is definitely temporal relationship between the AC inhibitor and cough, a few cases we find it that after beginning the AC inhibitor, after a few weeks the patient is starting cough. So in that case, it may be evident that if we should stop the drug and see. But as you are telling, that is also very common that the patient is taking the AC inhibitor for years, and now at any point of time the patient is developing cough. So we should not blame that drug only for this cough. So we should keep our mind open and we should keep on investigating all the possible causes. And side by side, I would prefer to change the AC inhibitor to some other drugs like ARB or anything, and just to have an additive effect that whether the stopping of the drug is causing the cough to subside or not. We should not point out to that drug only in that case, definitely. And regarding that hypersensitivity pneumonitis, as you are pointing out, though it is included in the ILD group or restrictive lung disease, but this is very typical of hypersensitivity pneumonitis in spirometry to have small airway obstructive features. So it comes with obstructive features that masquerades asthma in many cases. But the point, reversibility and variable airway obstruction by any means, by bronchoprovocation test, by establishing diurnal variation by peak flow metry charting, or some seasonal variation and atopic history. So those things has to be given more priority than just having a single spirometry and having a obstructive pattern and stempling it asthma and excluding other things that should not be there.
I think we over the time, so we conclude the session. Thank you everyone. Thank you very much.
So after excellent panel discussion on asthma mimics, now we close the session. I thank all subject experts, panelists and moderator.